Good morning, everyone. Welcome, and thank you for joining us for today's Knockout Opioid Abuse Day Learning Series webinar, The Opioid Crisis, where we stand as 2024 concludes. And I know many of you are joining us who joined us back in January when we had our two same expert panelists speaking about um, the opioid crisis and what we were facing as we started the year. So I know it's of great interest to many of us to see where we stand as the year concludes. And so thank you for joining us. A few housekeeping items. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has been approved by NJOEMS for one EMT elective CEU, and the Partnership for a Drug-Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers, and this program is eligible for a maximum of one Category A hour. We have one disclosure from our faculty. Jason Piotrowski discloses that he is a former shareholder at Merck and Mind Medicine. And PA planner Dean Barone discloses that he serves on the Speakers Bureau of Ethicon and Johnson & Johnson. And all other panelists, faculty, and reviewers have no relevant financial relationships to disclose. And all relevant financial relationships have been mitigated. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the New Jersey Office of Alternative and Community Responses, and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I'm so pleased to have our expert speakers with us today, Dr. Lewis Nelson, professor and chair, Department of Emergency Medicine, chief of the Division of Medical Toxicology and Addiction Medicine at Rutgers, New Jersey Medical School. So thank you, Dr. Nelson, for being with us. And Captain Jason Piotrowski, the Executive Officer of Forensic and Technical Services Section of the New Jersey State Police. So I thank you both for joining us. We're really looking forward to hearing all of the information that you're sharing with us today. And Dr. Nelson, I am going to start with you and turn the presentation over.
Great, thank you, Angela, and thanks for having me here. And I want to thank the partnership and all of your partners for putting on this symposium. I think it's always a highlight for me. Let me just share my slides if I can. Okay, hopefully that looks good to you. You know, when I got the title or the recommended title, I was really intrigued because you don't really sit back often and think about the prior year that you've just been, living through. And, often years don't change. Things don't change very much as time goes on. But I will say that when it comes to the opioid landscape in the state and region, there really has been quite a paradigm shift over the past year or so. As you know, I have no financial disclosures, but I do want to sort of highlight when I obviously work in an emergency department and I see people come in freshly, brought in after an overdose. Typically, I'm involved to some extent with inpatient care and long-term care, but the majority of my work is in the emergency department. If you compare what we used to see, say 2 or 3 years ago, to what we see now, there's a much larger number of people who are in the emergency department at any given time with an opioid overdose. And it's not simply because the number of people who are overdosing with opioids has increased. There's something fundamentally different that's occurred. And I think I want to spend a lot of the time walking through what those changes are. And before I do that, I want to lay some background material, a little pharmacology, a little bit about the epidemiology of what's going on. Then we'll get into some of the clinical aspects and treatment aspects which I think are really important. But to set the stage, I think it's important to understand that an opioid is an opioid is an opioid. Now, there are some differences in their pharmacology, which means how they work or how they move throughout the body, a concept we would call pharmacokinetics, meaning movement. But what they do on the opioid receptor in the brain is fundamentally the same. So while there might be some differences in the various opioids in terms of how long they last and aspects like that, for the most part, they really are the same. When they cause harm, they do so through stopping your breathing, right? And they do so through making you sleepy or unconscious. But really, the thing that kills you, of course, is that respiratory depressant effect. It's important to understand terms. And I'm very particular when it comes to these things. And I'm going to run through these really quickly. And if you want to talk about them at the end, we can. The term abuse is a term we tend not to use anymore. We usually say use. And it really is use for the feeling that the drug engenders. And we know that opioids are sedating and euphoric, and they make people feel good. They do make you feel sleepy, which is why they're sometimes classified as narcotics, a term that we don't really use in clinical medicine because it's a much more of a legalistic term. Remember, cocaine is also a narcotic, and it certainly doesn't make you sleep. Tolerance, of course, is the need for more opioid to get the same effect. It's often thought about as the effect of the opioid is wearing off, receptors are changing to make the drug less effective. Dependence, which is sometimes confused with tolerance, means withdrawal upon cessation or reduction in dose, right? So in order to have a withdrawal syndrome, you need to be dependent on a medication. Right? Hyperalgesia, which is probably the driving force of the opioid crisis for the first 20 years of it, is related to the fact that opioids themselves lead to an increased sensitivity to pain. And we call that hyperalgesia. Another sort of related concept is called allodynia, but hyperalgesia is probably the active component here. When you take an opioid, it dulls the pain, but then you develop essentially a tolerance to the pain reduction. And that is hyperalgesia. Right? Addiction is a wraparound term which can occur from any of those prior mechanisms, but it really means compulsive use despite harm. Right? So it is a psychosocial construct. We sometimes use the term very loosely. We talk about caffeine addiction. I'm addicted to caffeine is just an example. Obviously, nobody is harmed through the use of caffeine. Nobody's robbing banks or selling their body like they do for other substances for which we much more classically think about addiction. But we'd like to use that term. It's kind of a term of art, perhaps. And then overdose, of course, is the consequence of taking too much. Overdose in my world does not mean death, right? In the medical examiner's world, I think we often think about overdose equaling death. But in my world, overdose means you took too much and you're suffering the consequences. Of course, all of these lead or are part of opioid use disorder, which is the construct we now think about when we really think about addiction. And there's sort of classical descriptions of it, but in a fairly simplistic way, we think about all of the things that happen when people use any opioid, and it doesn't matter if it's methadone or oxycodone or fentanyl or any of them. These all occur with any opioid, and they all can lead to death, and death by respiratory depression when you take too much. So that's the similarities between all of the various opioids. It's important to look at where we've come in the past 20 or 30 years with opioids, right? I don't want to spend too much time on this other than to point out, of course, that fentanyl is, and its analogs are, the primary driver of the opioid crisis and opioid deaths right now. Now, you can look to see there's a little bit of a flattening out here, and we'll see where that goes in a little while. In a few slides, I'm going to show you some more up-to-date information. But certainly, fentanyl is the big driver of all opioid-related deaths. But don't write off prescription opioids. As much as they were the inception of the crisis, going back 25 years, they're still pretty much at about the same rate of death as they were for the past 15 years. What's happened and why some people say there's no longer a prescription opioid epidemic, it's a fentanyl epidemic, is that the fentanyl death rate and number has just far exceeded that of prescription opioids. But prescription opioids are still there, and they still lead to substantial numbers of deaths. But we're talking about the difference between 60 or 70,000 versus 10 or 15,000. So clearly, fentanyl and its analogs are the problem. We've seen a rise in the number of stimulant-related deaths, but just to be really clear, when you die of a stimulant, you're not dying of the stimulant. You're dying of something else, trauma or some other sort of situational response, not the drug itself. The opioids kill you directly. The stimulants put you in situations that cause you to die. I mean, it's very uncommon to actually die of the stimulant per se. Right? It happens, of course, but in general, it's not the stimulant that does it. In toxicology, we have this really important concept, and I just want to drive home. Dose makes the poison, right? And you can read the longer description of that, but basically, if you think about it, the more of anything you take, the more dangerous it becomes. There's nothing that's not dangerous if you take too much of it. And the corollary of that is that everything is safe in a tiny enough dose. And that's true. Remember, you can take a small enough dose of cyanide and not get injured, not get harmed. But if you take too much of it, obviously it's going to be a problem. But I say this because people confuse these two terms a lot: dose and potency. Dose is the amount that you've taken. I've taken 5 milligrams, I've taken 100 milligrams. Potency is the number of milligrams per kilogram of a drug it takes to have a specific effect. So people like to say fentanyl is more potent than heroin, and that's why it's dangerous. That's not a correct statement, right? Potency, as you can see in the slide on the right, where I'm showing you 3 different lethal doses of any of the 3 given labeled medications. Potency changes between the 3 drugs, but you could take enough of any of those 3 drugs to harm yourself, to die. But you could also take a low enough dose of any of those 3 drugs to not have a problem. And the clinical implication of that is that all opioids are dangerous if you take the wrong dose, but all opioids are safe if you take the correct dose. And that's where overdose comes in, right? It's very easy to mistake the correct dose, particularly with these very potent drugs, because such little quantities are required in order to get the given effect that you're looking for. And in most of our cases, it's euphoria, right? The problem on the street, of course, is you don't know what you're getting, right? Authentic oxycodone tablets have 30 milligrams, have whatever the number of milligrams it might be, 5 or 10 milligrams or 30 milligrams per pill. When you buy counterfeit medication or counterfeit prescription opioids, you have no idea what's in there. There's just no way you could possibly know that. And when you buy street drug, of course, in powdered form in these glycine envelopes, you really have no idea what's in it. And it's that variability in quantity that makes it so difficult to properly take the right dose, which is why overdose is such a problem. If we knew exactly how much was in every pill in every bag, we would be able to titrate the amount that we want, but we can't do that. Of course, the problem with the opioid epidemics I've already highlighted for 20 years was about prescription opioids. And our mantra was to just not dose people with high dose opioids, keep opioid naive people opioid naive, and keep the dose restrained that people are taking. Of course, we've moved on beyond that, and now we're really trying to think about harm reduction and preventing death, because we've recognized that the impurities, the variabilities of the quantity of fentanyl and other opioids in the street drug now is just impossible to dose correctly. So we can't keep the dose right. We have to prevent the harm once it occurs. And just to point out here, we love naloxone. I'm a big proponent of naloxone. We'll talk more about naloxone in a little while. But naloxone's great, and it keeps people alive. It gets them to healthcare, right? And you can see 2 nice studies here by a colleague of mine in Boston who really show that even after receiving naloxone by EMS or in a hospital and being discharged, the death rate in the following year and in any given breakdown of time after that far exceeds the death rate for almost any other disease that we see in clinical medicine. A 15% death rate in a year is extremely, even a 5% death rate from any disease in a year. And the disease here, of course, is opioid use disorder. And what it means is that we can't just give people naloxone and say we're done, right? These folks need to get into treatment, right? And treatment engagement is really important, because giving someone naloxone and letting them go without any sort of treatment engagement might save their life today, but it really only postpones their death till tomorrow or next month. We need to get them into treatment. Right. Harm reduction is great. I'm not going to go through all these, but many of you are involved with the harm reduction efforts. Some of these are a little controversial, but some of them are really evidence-based, like naloxone utilization is clearly something we know saves lives, right? Less controversial, of course, is addiction management. Whether you are somebody who believes in buprenorphine or methadone as the primary treatment strategy is up for debate, which is better. Both of those evidence-based strategies, though, far exceed the abstinence-based strategies. And I know some folks out there practice in an abstinence-based model. Most of the treatment programs in New Jersey, in fact, are abstinence-based models. But the evidence clearly supports that using medications to treat OUD is far superior than not. And I am a strong proponent of buprenorphine, and I support methadone as well. And the world of buprenorphine and methadone has changed, but it's not the focus of our discussion today, but just something to think about. Now, what I really want to say about 2024 and about even the past few years is that there's been a lot of bad messaging and a lot of misinformation. Right? This is unintentionally misinforming, because I think the concept of xylazine as an emerging threat was probably, early on in its tenure here. It was considered to be something that was going to be problematic. We've come to learn, as I'm going to show you, that xylazine is probably not a threat, and in some weird ways, it might actually be, and I'll put this in quotes, perhaps, a good thing. Right. But xylazine clearly doesn't have the effects that people thought it was going to have when it first came out. Messaging is really important. So xylazine is a veterinary anesthetic analgesic agent. You can see on the left, most of it now comes through illicit channels, and it's not diverted from veterinary supplies. This is not a medication that we use in humans. There are similar medications we use in humans. One of them is called dexmedetomidine, and we'll come back to that a little bit later. The brand name of that is Precedex. And for those that work in hospitals, you'll be familiar with that medication. But xylazine itself is a sedative that we use in veterinary medicine. If you're interested in reading a little bit more in depth, we wrote a piece last year that went through a lot of what I'm sort of alluding to here, but obviously in much greater depth than I'm going to cover in just a few minutes. Now, what you hear some of the rhetoric about naloxone and the misinformation is that it's not reverse-mind naloxone. Well, and that is absolutely true, but it's not relevant because it's not an opioid. It's a sedative. It works not like a typical benzodiazepine sedative, but it works an alpha-2 agonist, right? So it shouldn't be reversed by naloxone. Some say it worsens opioid overdose death rate, and it doesn't. There's no data to support that. There's no withdrawal syndrome associated with it that we've been able to characterize. And yes, there are wounds, which I'll show you in a moment. But there are still some questions about the true etiology of those wounds, and we're still working on better understanding that. You'll see graphs like this from the CDC, which are very important, which shows a rising incidence of co-involved, a term they use, death in people with fentanyl and xylazine. What this is missing, and the terminology is a little off-putting to me, because this is an association, and there's no suggestion there's actually causality here. More xylazine in the street drug means more people who die of fentanyl overdose are going to have xylazine in their bodies. So if you drew a line of xylazine prevalence in the drug supply, it would parallel the rising line that you see here of xylazine-involved death rates. In fact, in some studies that have looked at this, you can see on the left, a study done at Mount Sinai that shows that, in fact, in almost every parameter looked at, those that had xylazine in their body at the time of overdose did better than those who didn't have xylazine in their body at the time of overdose. And on the right, you can actually, as the blue line, the xylazine availability started to rise in Ohio, in the city in Ohio, this county in Ohio, the death rate from fentanyl actually started to fall. Right? Very important. And you could see that over the past couple of months, we've actually seen a fall in the death rate associated with fentanyl. And the New York Times piece put forth a provocative concept, which is, in fact, maybe the drug supply itself, as it evolves, is leading to a reduction in death rate. Maybe the other harm reduction efforts are catching up and doing well, but the newest change that we've seen associated with death rate falling is, in fact, the change in the adulterant component of things like xylazine. Of course, xylazine causes wounds, and I'm sorry for the picture if it's too graphic, but we do see these, and they're terrible and they're horrible. They are very sort of mobilized with the increasing prevalence of xylazine. There's not a strong biological basis for the association, but just given the observational findings, it does seem to have a strong, at least potential causal relationship. And we don't see this so much in northern New Jersey, but I know in southern New Jersey, in the Philadelphia area, these wounds are extremely prevalent. We've seen a handful in the institution that I work in. Most recently and most interesting, I think, is that xylazine, and I'll show you in the next slide, prevalence in the drug supply is actually falling. And a new adulterant is something that we're seeing called medetomidine. Now, medetomidine, you might remember, sounds a lot like dexmedetomidine, which I mentioned before, which is a xylazine analog that we do use in people in the dex form. Right? This is the racemic form. This is dex and levo together. But it's a very similar drug. It's a sedative. And what we've seen a lot, and one of the reasons we've seen such an increase in the number of patients in our ED is because xylazine and medetomidine was very prolonged sedation, right? They may have actually reduced the death rate in people who use fentanyl, but they've increased the length of time that people stay sedate. Most of the opioids are fairly short-lived. They last an hour or two. People should wake up. These folks are unconscious for 6, 8, 12 hours or more, right? And the bradycardia, the heart rate reduction in people with medetomidine in their body has been fairly impressive and dramatic. I mean, there's folks who come with heart rates in the 30s, very concerning to us because that's just a little too low to make, to make us comfortable. And then they stay sedate for a fairly long period of time. This is new data that was just posted a couple of days ago out of Philadelphia, which again is not northern New Jersey, but probably very similar to what you see in southern parts of New Jersey. You can see that the xylazine content of the drugs over the past couple of months has actually fallen dramatically as the medetomidine adulteration rate has risen fairly dramatically. And that's consistent with what we're seeing in REDs in the north. We don't have this robust data, at least I don't, and maybe it's out there to show the relative rates of xylazine and medetomidine. Naloxone does not reverse the effects of xylazine, yet it is the drug of choice, primarily because we're treating fentanyl, not xylazine. Xylazine itself does not need to be treated. It's fentanyl that kills people. And naloxone is great, whether you buy the brand name or one of the various generics or non-prescription products. It's a terrific drug. It all works. It always works. And the end point of success is not awakening, because the xylazine and the medetomidine prevent you from waking up, but it's breathing, right? And the naloxone will still improve your breathing rate, even if you don't wake up. So don't give multiple doses. Just give your single dose. Watch the respiratory rate. Make sure it goes from 2 or 4 or 0 up to 4 or 5 or 6, which is enough to sustain life. Stay away, in my opinion, from the high dose naloxone. There's good data to show that it only causes a severe and prolonged precipitated withdrawal syndrome. It's a good concept. It's not necessary. These other opioids, the fentanyls and analogs, do not need more naloxone to reverse. And I think I feel somewhat strongly about staying away from the long-acting opioid antagonist nalmefene, because it works unquestionably, just like naloxone does. But when it causes withdrawal, it will produce a prolonged withdrawal syndrome. This drug lasts 6 hours, not 40 minutes. And while the concept makes sense, and we put out a position statement about this, it's not really studied adequately to make me feel comfortable about it. So to finish up, I'll remind you all, an opioid is an opioid. There are subtle pharmacological differences, but from the medical perspective, it's all about respiratory depression. If we find somebody who's not breathing, we can do one of two things. We can bend down and we can put our mouth to theirs and breathe for them, or some alternative to that, like bag valve masking if you're carrying one, or we can give them naloxone in a conventional formulation of 4 milligrams intranasally. Right. Although we have an iotrope component in prescription opioids, as you know, it's almost all fentanyl related. But we do know that as we've seen an increase in xylazine and perhaps medetomidine, that's yet to be determined, the death rate from fentanyl does seem to be falling. Now, there may be other contributors to that. Of course, there's a million reasons this could be happening, but I'm a little bit intrigued by the data that I've showed you that shows that xylazine may actually have, if not a protective role, there are other reasons why we might be seeing the reduction in fentanyl index. We could talk about that later if anybody's interested. This is my contact information if anybody would like to talk, but I know I'll have some time at the Q&A later. Thank you.
All right. Thank you, Dr. Nelson. And I know we have a number of questions for you, but we'll hold those until after Captain Piotrowski's presentation. So thank you. And now I'll turn the presentation over to Captain Jason Piotrowski. Jason, welcome.
Thank you, Angela, and thank you, Dr. Nelson, as always. Great information. And you would think that Dr. Nelson and I compare notes because we usually have very similar messaging, but we have not. We just happen to think somewhat alike in this realm. So again, I'm going to go through. We will cover today. We're going to cover the national landscape, the state of New Jersey drug environment, fatal, non-fatal overdoses in New Jersey, fentanyl, other persistent and emerging threats, and then efforts to reduce drug harm here in New Jersey. So this is from the CDC and the Wonder database. And again, I highlighted there under accidents, unintentional injuries, that's what where overdoses fall under. So you can see it's right under heart disease and then malignant neoplasms, which is cancer. And then overdoses fall into that category. So that's kind of what the country looks at. And it's, attributed there in that third cause of death of all ages in the United States. Again, Dr. Nelson and I have very similar opinions. We have some of the same slides. You can look at the provisional counts of overdose drug deaths from the United States from the CDC, and you can see that, it's starting to trend down. But with that, if you look at all injury deaths here, and I talked about that category, poisoning deaths or, where overdoses fall into that category, that's still more than motor vehicle traffic deaths and firearm deaths combined. So that just really speaks to the magnitude of the problem that we're still facing. Even though we're going to, show some decreases, we're still facing a very large problem. Again, so the title of the slide is "Are Overdoses Down?" because that's been a debate and question and is underreporting and things like that. And I don't think it is. So that's why I'm gonna cover it. You can look here. Again, this is CDC drug overdose death provisional data, and that's showing the entire country here. And the blue is good where you want to be. That's showing decreases. In the orange ish color there, that's showing increases. And you look at these 12-month periods ending in different parts of the year. And I present this a lot, so I was actually able to pull these from old slides. But you can see the blue kind of coming across the country. So this trend down that we're seeing of overdoses, it isn't just in New Jersey, it's all over the country. And it's something that everybody is kind of experiencing and moving, hopefully overtaking the whole country there in blue. It's what we would like to see. Now, we're going to talk about New Jersey here specifically. And again, we're looking at those numbers there. One thing to point out here, this data comes from the State Chief Medical Examiner's Office, and it is preliminary data. The New Jersey Department of Health will publish data on this as well in their suitors database. But this is 2020 to 2024. They're suspected and they're not confirmed yet. But we see that we may have peaked depending on what happens, anywhere from 2018 to 2021 may have been our peak there, depending on, again, what happens when all the overdose deaths are accounted for. But we are seeing this downtrend here. And while they're trending in the right direction, it still equates that number that we're projecting for the year, that 1956, that's somewhere between 2015 and 2016, which is great, but that still equates to more than 5 people every day in New Jersey. And we need to keep up all our efforts to continue to push this number down. And there's a lot in New Jersey that we're doing here, both from the government side and county, local, state, and then a lot that's going on the ground in the communities. So this gives more of a historical perspective by county. And what really stands out to me here are 2 things. Essex County has gone up significantly over the course of the epidemic, but this year's doing better. And then really on the bright side of things here in Ocean County, they're seeing the best numbers they've seen, since at least 2011. And again, that's just really positive direction that a lot of counties are seeing and the state is seeing as a whole. But Ocean County in particular, that number there of 10 is the lowest they've seen in quite some time. So kudos to all the work in the Ocean County Health Department and everything that's going on there. So now this is going to show more recently looking year over year, and that's January through September of 2023 to January, September of 2024. Most of it is green, is positive, is reductions. And the red there, some of them are very small, like +2, and no overdose is acceptable. But you see some very small numbers, except for Somerset County. They're showing some problematic preliminary numbers, and something certainly to investigate further. Now we look at the projected year-end totals for naloxone administrations, and what's really interesting here is that we're seeing a lot less first responder naloxone administrations compared to 2023. Our projections are about 11,500. Now the great thing is that's 11,500 people who are getting naloxone from first responders this year, likely projected. That's amazing, but it's also a 21% decrease. And you see there on the right, this was collected from our New Jersey State Police Drug Monitoring Initiative and their OD-MAP program. And anytime a law enforcement officer has responded to a scene of an overdose to administer naloxone, it's already been administered by privately, by family, friend, layperson, however you want to define that, not a first responder. But that 18%, again, almost 20%, that's a very good number. And that really speaks to the naloxone saturation. Our Department of Human Services has handed out, made available hundreds of thousands of kits, and I'll talk a little bit more about that later. And our NJ State Police Operation Rise is taking advantage of the partnership with Human Services, and they've handed out over 100,000 of those kits as well. But again, that early intervention of naloxone before first responders even get in there is likely beneficial in helping bring these overdose numbers down as well. Now, this is just for everyone's information here, and it's a little bit more detailed with the naloxone administration by county. And then the State Police DMI, the Drug Monitoring Initiative, pulled out by city as well. And then they looked at, the municipal residents, because that's important to understand when you're serving the population. You're looking at overdose numbers in a certain jurisdiction, but you want to make sure your efforts are for the people they need to be. So, they're the two most cities with the most naloxone administrations. Newark has 73% of our residents of Newark. And then in Camden, it's a little unclear because it shows 36% of documented municipal residents, but there's a lot of unreported there. There's 46% unreported. So it's a little bit of an unknown. But again, it really speaks to, if you need to serve the populations, if you need to get out in the community and do outreach, which is really important, and hand out naloxone and things like that. Again, it's just some information for you all to kind of understand and how to be more effective in that outreach and that overdose prevention. So what are we seeing here with as far as the demographics behind naloxone administrations? Well, 74% of the naloxone administrations involve subjects 35 and older, both male and female. That's, again, those numbers have been climbing for years in the older population. And you can see there 55 and older represents 35% of the overdoses, not something we would see historically. I've talked about this in this venue in the past, and I'll talk about it again today. While we are seeing decreases, again, our Black and African American population in New Jersey is roughly like 14%, but overrepresented in naloxone administrations, 34% of the naloxone administration. So again, when you're talking about resource allocation and outreach, we want to be pointed in the right direction. So this is just good information to have and understand who is disproportionately affected and kind of needs more support and resources. We're going to talk about fentanyl now and the historical impact of fentanyl, and I won't get too much into this. Dr. Nelson kind of covered this a lot. Really, we're talking about that green line there, which is fentanyl. And you see that most of those overdoses, the overdose deaths, and this is nationwide information, are fentanyl is implicated. And there's interesting things happening with fentanyl currently. We'll get into that in a minute. So opioid seizure data. So this represents opioids that have been seized by law enforcement throughout New Jersey. And we see that the decreases there, the projected year-end totals of 5,925. That's going to be the lowest number that we've seen in years. And it's really an indicator to me that the demand is dropping significantly. And in a few slides, I'm going to cover stimulants, but I'll give you a little context there. In 2019, you can see there were 13,000 opioid cases that came to forensic labs in New Jersey, and methamphetamine and cocaine combined only comprised 6,000. So more than double were opioid cases, what law enforcement was seizing on the street and giving to forensic labs. Now, when we look at 2024, and you'll see that other slide later, if you combine those now, those stimulants, the cocaine and the methamphetamine, we're going to have about 5,925 cases for opioids, but 7,300 cocaine and meth cases. And that's a little bit the way we collect the data and the way we present it. We have more comprehensive opioid seizure data than because that's what we focused on. And we have less comprehensive when it comes to cocaine and meth. So it's actually probably more pronounced than that. And again, this indicates kind of a demand change and in the aggregate of all these data elements. And demand reduction is really key. And the way I like to think about it is that, if there's no demand, then the supply and what's out there and all these different drugs that are coming in is really irrelevant if there's no demand. So that's just something to think about. And I'll talk about later some of the possible reasons for the demand reduction, but certainly education, awareness, prevention, a lot of the work that Drug Free New Jersey does, certainly outreach, treatment, they like to play a major role in the shift from opioids, in my opinion. So again, one topic we're going to cover here, which is really interesting, is fentanyl depletion. And so again, you're seeing that brown line there is synthetic opioids, which is going to be primarily fentanyl, is going down, and that black line there is all opioid overdoses. So you see, obviously, the opioid overdoses going down, but the fentanyl, as well. The chart on the left there is the United States, and the one on the right there is specifically New Jersey. So fentanyl depletion, this is what researchers are saying. So Dan Ciccarone, if I'm saying that right, he's a physician and street drug researcher at the University of California, San Francisco. And this was an NPR article that I pulled up. And what he's saying is the fentanyl supply is drying up for some reason. And, hang out in the streets and talk to people, the drugs are hard to find and more expensive. He says, I hear from Ohio, West Virginia, and Maryland, Arizona, they're all telling me the same thing, some sort of supply shortage on the street. And in the Brookings Institution, Vanda Feldman Brown there is saying that drug gangs appear to be trafficking less fentanyl and are also adulterating or weakening the potency of the fentanyl being sold. And that speaks to what Dr. Nelson said with the xylazine is a less potent substance and really somewhat of a gift. Everything usually goes more potent. The iron law, prohibition, we went from oxycodone to heroin to fentanyl, and now it introducing xylazine and its prominence in the drug supply is much less potent, and the lethal dose is a lot more than what fentanyl would be. And now, does any of this have to do with the cartels? And you can see our Wall Street Journal article from October 2023, the Sinaloa cartel's message to members, stop making fentanyl or die. And there's some things I can share and there's some things I can't. We were privy to this, long before the Wall Street Journal article of this potential dynamic. And it appears that they are enforcing that. And there's another article there, El Chapo's sons bar fentanyl production in Sinaloa cartel, in Sinaloa, according to banners that they're hanging up across the region down there in Mexico. And so again, that's what kind of the media is reporting. And so when I'm at, the Office of Forensic Sciences here, the Forensic and Technical Services section. So I rely on the forensic scientists here as well for a lot of this. And so I was talking with some of the scientists and they were explaining to me the mass spectrometer data that they're seeing. So when they analyze the substances, I'm going to take you through kind of a story here. This image there is from the mass spectrometer, and it's a heroin peak. And this is what they would see years ago, a lot of heroin in the drug samples. But moving forward there, now you're seeing heroin and a little bit of fentanyl. Then it transitioned to mainly fentanyl, some heroin, and some other substances in there. Then we see xylazine and a little bit of fentanyl. And these are kind of relative ratios to each other in there. They're not full quantitative analysis to be specific about that. And now what you see in that image there on the right is xylazine, a lot of xylazine, some fillers and numbing agents like procaine, lidocaine, tetracaine, things like that. Some bromozolam that we've seen. I'll talk a little bit about that. And then just a little bit of fentanyl. They're saying that we see like these small little, not much fentanyl in these samples that they're seeing is becoming the norm. So that's what we're seeing when we look at this under, the scientific instrumentation. Again, Dr. Nelson kind of talked about this. Look at the trend we're seeing in 2015 when drugs were submitted to the forensic labs. One drug was 94%. Now there's only one drug being in that sample is about 8%, which is alarming in that, people don't really know what they're getting, right? And now you see 5+ drugs in 2023, 13% of the time. It was 0% in 15, 16.2% in 17. It's up to 13% now. Xylazine in New Jersey, I'm not going to belabor this. We talked a little bit about this and Dr. Nelson mentioned this, but we're seeing, a lot of xylazine is mixed in, and that's often one of those drugs in the samples with fentanyl. So drug treatment data, I just want to talk about that a little bit. This is really encouraging and interesting. So this is a cross section. I got to explain this. It's the first 6 months of the year for these years to kind of compare apples to apples from 2012 to 2024. And I highlighted there when we started to see the increase in opioids of the treatment programs in New Jersey, they were really responsive, obviously, and a lot of people were more people were receiving treatment for heroin, appropriately so, corresponding to what the need was and the demand was. And you see it in 2024, it's going down, and you can see, and this is something that people are concerned with. Alcohol now has been increasing really since 2020, and alcohol use disorders becoming more prevalent in New Jersey as well. And again, one thing I want to point out, there are many new medication for opioid use disorder initiatives that is not in this data and also has a major impact as well. But it's really a testament to what Human Services is doing and a lot of the legislative actions. You can look at this again, that we're showing the primary drug increasing, alcohol increasing, and heroin going down. And again, the white population in New Jersey is becoming less impacted in overdoses and receiving less treatment, and the Black population is going up in receiving treatment services. And that also corresponds to what we see in the overdose environment. So what's the current fentanyl outlook in New Jersey? So the supply indicators, lower fentanyl ratio identified in forensic testing, reportedly harder to find fentanyl, drug samples increasingly contain multiple drugs. Demand indicators, opioid seizures are down. So I'm just kind of, summing up some of this. Less people are utilizing treatment for opioids than in the past. And nationwide indicators, we're seeing overdose deaths decreasing, fentanyl-related deaths decreasing. So in 2015, I had the opportunity to speak with in the League of Municipalities, and it made a lot of sense that fentanyl was going to take over, just because of the supply and demand dynamics, the magnitude of efficiency, production of fentanyl, and the how lucrative it is compared to what heroin was, and that obviously the potency as well. But this 9-year cycle, it feels like, I guess it was about 9 years ago, I feel like it's coming to an end, and it definitely looks that way. And so the current outlook, the illicit drug market transitioned from being primarily demand driven to primarily supply driven over the last couple of decades. And two large cartels have had a tremendous influence there. So many indicators point to a decreased fentanyl supply. It's hopeful that will persist, but it remains unknown. And there's potential for others to fill that void if there is a demand. But the demand seems to be decreasing. It's likely, but not definitive, that the fentanyl-related overdose will continue to decrease. And I'm really hopeful for that. Again, but now we're talking about stimulants, and this is sometimes it's cyclical. We saw late 70s, early 80s into the 90s. You saw crack and cocaine, and then the opioids, OxyContin, oxycodone, heroin, fentanyl took over for about the last 15, 20 years. And now it looks like, and I referenced this before, we're seeing more cocaine and methamphetamine cases than we have ever seen. One thing I'll point out there is that a lot of people attribute this, and this is debatable, and I'm not going to quite weigh in on this, but the overprescribing of prescription opioids are implicated in the opioid epidemic. And so there is a theory out there that the overprescribing of stimulant medications, primarily ADHD medications, are going to lead to a stimulant crisis. That may or may not be the case. Again, I don't want to weigh in on it, but I do want to socialize that theory that's out there. So what are the other threats out there? Nitazines. It's another potent opioid, and the DEA put this out in 2022, warning of that. We're seeing some nitazines here, but not a substantial amount. Bromazolam, all over the country. That's a CDC report. You're seeing it in San Francisco. You're seeing it in Chicago. Talking to some colleagues, Vermont, Virginia, we're seeing increases in bromazolam. Delaware had an issue with a lot of suspected overdoses. What was interesting there is because they were administering naloxone, and there were reports of seizures, hypothermia, myocardial injury following bromazolam poisoning. They were attributing these non-traditional symptoms at scenes of overdose. Naloxone wasn't responsive, and they're attributing that to the bromazolam there as well. So we are seeing it in New Jersey. In the second quarter, we had about 6,000 pills with bromazolam, which is a benzodiazepine. It's similar to Xanax. We've seen it mixed into the cocaine supply. That was 5,000 specimens is one case, to be fair with that. In the third quarter, we see another 31 cases of bromazolam and 1,300 pills. So vaping, this is something, again, to keep an eye on. This is a CDC report. In the US, the leading route of drug use involved in overdose deaths changed from injection to smoking. And you can see those couple of illustrations there showing that. And what's interesting about vaping is this is a youth study. You can see the map there all over the country. They did this survey of high school students. A lot more females than males across the board there, whether it's ever used, currently used, or daily use. And that's something we don't traditionally see as well. In New Jersey, the median age for vaping, and this comes from our Office of Forensic Sciences here in seizure data. 18 years old is the peak there for amount of people in that group of 2,849 total people. Reported race is primarily white, and reported gender for those seizures and those arrests are primarily male, despite kind of females using vaping products more. Why is it problematic and something to be aware of? We are seeing, these numbers are small, but we're seeing in ODMAP, we're seeing vaping related overdoses increasing. Again, small numbers, but increasing. Naloxone administered about half the time. And, male about 58%, female about 42%. So I'm wrapping up now. And what I really want to just end here really quick. So New Jersey's efforts to reduce drug harm, so many significant efforts. That's one thing I'm really proud of. Not me particularly, but just the state of New Jersey in general. Millions upon millions of dollars in opioid recovery and remediation. Efforts by Attorney General's office to really focus on the intersection of public health and public safety. Legislative actions. Harm reduction centers are now authorized in every county, and DOH has achieved a milestone of 50 authorized harm reduction centers in New Jersey. Expansion of medication for opioid use disorder. Naloxone available at almost 700 pharmacies across the state. Drug paraphernalia laws have been updated to exclude harm reduction supplies, which is really important. Limits on opioid prescribing, naloxone leave behind kits legislation. So anytime a police officer shows up to the scene of an overdose, he's got to offer to, or he or she has to offer to leave a naloxone kit behind. Again, and when we see that 18% of the time when law enforcement responds, that naloxone's already, there's been an early intervention, or someone has already administered naloxone prior to a first responder or a law enforcement officer on scene. The naloxone saturation there impact the New Jersey Department of Human Services. They have a naloxone direct and naloxone 365. These were really big programs here. They've got the naloxone direct it's agency and organization based naloxone distribution. So they give it out to law enforcement, EMS, fire, first responders, treatment providers, shelters, libraries, harm reduction agencies, et cetera. They have 1,400 agencies and have distributed 215,000 kits. And then naloxone 365 in those pharmacies, almost 700 pharmacies. In 2024, more than 50,000 people picked up naloxone at pharmacies, or kits had been distributed, is probably a better way to say it. And then total distribution since the program is over 115,000. Now I'm sorry, 132,000 is the more updated number. So again, just a lot of efforts in New Jersey to reduce drug harm. And the last thing I'll say is, again, demand reduction is key. The outreach, the prevention, the awareness, the education, a lot of the work that Drug Free New Jersey does, certainly, the treatment. So we want to keep driving these numbers down. We want to do a lot of prevention work and a lot of treatment work. The demand reduction, again, I'll say the third time, is key there. And why do people use drugs is a great question. And a lot of times, a lot of the work I do and the presentations I do, we talk about trauma-related incidents, whether it's adverse childhood experiences. There's a strong correlation between prevalence of adverse childhood experiences leading to substance use disorder in adulthood. So that's something really to think about, because there's a really good study, Doobie et al., 2003, where they showed these links between substance use disorder in adulthood and adverse childhood experiences. We also talk about things like military personnel, how they're more likely to get prescribed opioids, specifically with seeing overseas action and PTSD and co-occurring disorders and things like that. But again, both those things kind of go back to trauma. But again, that's going to be key for prevention, to keep these numbers driving down and to stop people from being exposed to these dangerous substances. And that's all I have. Thank you.
Thanks so much, Captain. I will say that your information was very hopeful. I think that's the word that you used, and I agree with that. And I appreciate you specifically mentioning vaping, because that is something that we are hearing so much, especially from our educators and our community leaders, looking for information on preventing or educating about vaping with our youth. So thank you for addressing that. We have, I know, a number of questions that we're going to try to get to, at least some of them. But in the meantime, I just want to address two things. Yes, you'll get a copy of this presentation. You'll get the slides and a recording, and information on how to get your continuing education credit for whichever field you're in is available on the screen right now. The links on how to get that. So, Dr. Nelson, I'm going to just go right to you just with a quick question. Can you just explain a little bit more about hyperalgesia and how that relates to most patients' use of opioids?
Yeah, it's always a little tricky to think about this. Most people understand tolerance, right? Where the amount of drug you need to get a given effect goes up over time because you become, your receptors adapt and you become tolerant. In other words, you can tolerate higher doses of any given medication. We sort of think of it in a way as that the effect of the drug is wearing off over time, needing more drug to get the same effect. Hyperalgesia, in a way, is the opposite, yet mechanistically fairly similar. So instead of thinking about the drug wearing off, think about the pain getting worse. Right? It's a normal adaptive mechanism that we have in our bodies to stresses. So if I'm giving you some medication that's chronically suppressing your pain actually worsens, requiring more medication. So instead of thinking about the worsening pain over time as the pain medication wearing off, think of it as the pain itself getting worse. I mean, this is no different than the tolerance that and effects that develop from any other medication, whether it, or substance, whether it's nicotine or alcohol. So it's specific to opioids in this case, but in fact, all pain medications, opioids being the most important one, can produce some degree of hyperalgesia.
All right, thanks. And then, um, Captain, there was just a question on the slide with the recent county trend information that you shared. Are those overdoses or fatalities?
Those are fatalities from the state chief medical examiner's office.
All right, thank you. Um, and now, Dr. Nelson, can you just talk about how tolerance impacts potency or dose?
Tolerance impacts potency or dose. I'm not, in other words, what makes tolerance occur is the total amount of opioid effect on the receptor. So if you take a more potent drug, you just need less of it. So the potency of a drug, if let's just say you have 10 units of an effect on that opioid receptor, you can either have 10 units of a drug that has a potency of 1 or 1 unit of a drug that has a potency of 10, right? But the cumulative amount of opioid on that receptor is the same either way. So with fentanyl, we dose people in micrograms. So a typical therapeutic dose I would give somebody might be 100 micrograms. If we were giving morphine, we would give, say, 10 milligrams, right? And if you do the math between those two things, 10 milligrams is 10,000 micrograms, right? Whereas 100 micrograms is obviously 100-fold less than that. And we know that the potency between morphine and fentanyl is about 100, and that translates into the dose. Now, obviously, tolerance develops with long-term use, but it's the amount. Now, the problems with fentanyl is that it's so potent, it takes such tiny amounts of drug to have an effect, invisible amounts of drug, right? Which means if I sell it to you in invisible amounts, you would never know you're getting it. So it's diluted in a substance, a cutting agent or a bulking agent, some of which is xylazine or another substance. But it's very easy to add too much because it's such a tiny little amount, right? So if I give you, I can easily put in 5 or 10 or 100 times so much, you wouldn't know you're getting it, which is why the street drug quality control issue is so important in overdose and overdose death rate from fentanyl. It's people aren't trying to die from fentanyl. They're just getting drug that has an unquantitated amount of fentanyl in it because it's such a potent drug,
No,
right?
and
Does that make sense? Hopefully that makes sense.
that does make sense. And I know, Jason, you mentioned that as well about looking at what was in the street drugs that you were testing them as well. And so, do you concur with?
Yeah, if you don't mind, Angela, somebody asked a question about nitazines, and I know the captain brought it up. And nitazines are just another equivalent of fentanyl. They're not fentanyl. They're just structurally different. But again, I'll go back to my original comment. An opioid is an opioid is an opioid, right? Potency may differ, but ultimately what it does is it binds to that receptor and causes you to stop breathing.
All right, thank you. I know we're running out of time. Um, Captain Piotrowski, I'm going to just go to you. Any last comments or thoughts you want to share with the group?
Yeah, I'll just echo kind of what I said before. This we've made great strides in here, but we need to keep our foot on the gas. We need to first thing harm reduction, stop people from dying, get people into treatment, and that will help reduce the demand if people are no longer using drugs. And then again, the education, awareness, prevention, and outreach, and keep all those efforts moving forward, and let's keep pushing forward. We're certainly still at an unacceptable level, but there's some progress being made, and we need to keep pushing forward.
Thank you. I want to thank you for the work that you do and for sharing all of this information with us. We appreciate you. Um, Dr. Nelson, any last comment? We have under a minute.
I don't have to say much. I think I fully agree with what was just said by the captain. It is hopeful that the data is showing that there's a downward trend. It's multifactorial. I'm sure there's some good law enforcement. I'm sure there's good harm reduction. I'm sure there's some good luck, and all the other things that we think about, treatment engagement, et cetera. It's a tough nut to crack. We're going in the right direction. Hopefully we continue to do that. I don't want to get too exorbitant, and exhilarated yet, but I mean, the fact that we're going in that direction for the first time in, I don't know, 30 years is very, very encouraging.
No, I think that's a great way to end. We have encouragement, we have hope. And again, I thank both of you. I thank you, Dr. Nelson, for the work you've done and our collaboration through the years, and look forward to collaborating with you again in the future. And for all of those in attendance, thank you so much for being with us. Thank you for being with us throughout the year. Thank you for the work that you do to help save lives in New Jersey. So we appreciate you as well. And I hope that you can join us as we look at a more national view of the opioid crisis to kick off 2025, the National Opioid Crisis, Current Trends and Solutions. It'll be on Thursday, January 30th, 2025. So I wish everyone well. Have a wonderful day. Have a wonderful season and be well.